Hello everyone. Today's topic is fungal rhinosinusitis. I'm Dr. Subhodha and I'm going to talk about this dreaded condition which was famous as the black fungus during the times of the pandemic. So it has lots of misconceptions about it due to the infamous black fungus associated with high mortality and morbidity, especially the scare which was spread during the times of the pandemic. But fungal rhinosinusitis encompasses more varieties in it, which are not so dangerous and which have very good prognosis and very good treatment options. So today we will begin with the topic of fungal rhinosinusitis. So there are 4 varieties of fungal rhinosinusitis. To begin with, we have fungal ball sinusitis. The second one is allergic fungal rhinosinusitis. The third one is invasive fungal sinusitis, amongst which we have 2 subcategories, which are acute invasive and chronic invasive forms. Out of these 4, the acute invasive form is the one which was infamous as the black fungus and which was the more dreaded and rapidly progressive form of fungal sinusitis, which was fatal for many patients. So let us begin with fungal ball sinusitis. So this condition is commonly seen in immunocompetent individuals. So these patients will not be having lots of comorbidities. So it will commonly involve a single sinus and it will be presenting with the symptoms and signs of chronic rhinosinusitis. These are chronic nasal obstruction, chronic nasal discharge, loss of smell, and mass in the nose. So whenever we see such a patient who is presenting to our OPD with a single-sided facial pain or a single-sided nasal discharge, we have to investigate further with CT-PNS. In CT-PNS, we will see a radio-opaque hyperdensity, which may be as opaque as a metal within a single sinus with surrounding bony sclerosis. We can see in this picture that the left-sided maxillary sinus is affected, but there is no involvement of the adjacent ethmoidal sinus or frontal sinus. The opposite nasal cavity and the nasal paranasal sinuses are absolutely normal. In fact, even the ipsilateral nasal cavity is looking very normal here. But we see a radio-opaque fungal ball within the maxillary sinus, which is marked by the arrow. So when the treatment, which is directed endoscopic sinus surgery, is done, we see that the sinus which is involved also will not have much signs of reactive inflammation. Like there may not be mucin, there may not be hypertrophied mucosa, but we will just see that there will be a fungal ball which has been successfully contained into the sinus by the immune system of the body. As I already mentioned, these are immunocompetent individuals without comorbidities. Hence, the body would have been successfully able to contain the infection within the single sinus. And the fungal hyphae would have interspersed within to form a fungal ball, which will be successfully removed by the endoscopic sinus surgery, and the patient will have a very good prognosis. So as I already mentioned, the treatment of choice is directed endoscopic sinus surgery. Perioperative glucocorticoids have an important role to prevent future recurrences. So both systemic and topical steroids for a short duration of approximately a month will offer great benefit in preventing recurrences. But everyone should note here that there is no role for antifungal therapy, even though it is a fungal ball sinusitis. Many of the clinicians who treat sinusitis, who refer patients to ENT surgeons for the management of the sinusitis, have this notion that whenever it is a fungal sinusitis, it has always to be treated with antifungal drugs. No, this variety does not require antifungal drugs, and it has been proven by evidence-based medicine. So neither amphotericin nor other drugs like voriconazole will be required in this condition. Recurrences are very uncommon. The main thing that is required in this condition is only a wide opening of the sinus by endoscopic sinus surgery and complete clearance of the fungal ball. Coming to the next topic, which is allergic fungal rhinosinusitis. So this again is seen in immunocompetent individuals. So they will not have comorbidities most of the times, and there will be evidence of chronic allergy to one or more fungi in these patients. This is very similar to fungal ball sinusitis, except that in these patients there will be a IgE mediated hypersensitivity reaction to the fungal ball which has been contained within the sinus. Because of this systemic reaction of the body, the inflammation spreads to the adjacent sinuses, and because of the fungal hyphae which are being carried through the mucin, allergic mucin which has been produced by the body, it will spread to the adjacent sinuses. So though it is non-invasive type of fungal infection, there will be one or more sinuses involvement, but most commonly, more than 50% of the cases, it will be on the same side. The patients will present with chronic rhinosinusitis symptoms and signs, as we already discussed, which will be chronic nasal obstruction, chronic nasal discharge, which may be anterior or posterior, and there will be epistaxis, there may be loss of smell, and there may be nasal masses protruding like nasal polyps. So, when the radiological assessment of the paranasal sinuses is done with a computed tomography, what do we see? We see hyperdensities within the sinus, just like that of fungal ball sinusitis. We see the sinus filled up by mucin, which will show like a soft tissue density within the sinus, which will be expanding within the sinus with bony expansion and thinning and sometimes even erosion. If the erosion is in the direction of the orbit, there will be intraorbital extension of this disease, and if it expands anteriorly, it may spread into the soft tissues of the face, and if it extends into the skull base, it may go into the brain. We can see in this image the right maxilla which has been involved, showing hyperdensities within, which is marked by the star. We can see that it has expanded medially into the nasal cavity, and it has also superiorly extended into the anterior ethmoidal sinus and into the frontal sinus. But we see that the orbit is untouched, as well as the other side is absolutely normal. So how do we treat allergic fungal rhinosinusitis? So these patients, as we already mentioned, will present with multi-sinus involvement and chronic rhinosinusitis symptoms. So we can begin, if they present very early, with medical management. So what are the medical management options we have? The most important are oral and topical steroids. If there is secondary bacterial infection which will manifest as purulent nasal discharge, then we can add antibiotics which may be broad spectrum or which may be taken as culture swab, and sensitivity can be assessed, and then appropriate antibiotics can also be started. Another important treatment option is antihistaminics in combination with anti-leukotrienes. So most important of all of these is oral and topical steroids. So they will be able to clear the disease in early stages without even surgical treatment. But whenever the system of paranasal sinuses gets affected more than one, or bilateral disease happens, we have to post the patient for endoscopic sinus surgery, which has very good prognosis. So endoscopic sinus surgery in association with postoperative glucocorticoid therapy will give very good prognosis for the patient in terms of less recurrences. But whenever the patients are non-compliant to the post-operative treatment, if they think that surgery has been done and there is no need for any further treatment, if they become non-compliant, then it has been noted that there has been cases of recurrences and recalcitrant diseases. So clinical evidence-based medicine says that antifungal therapy again has no role in these patients. There is no role of immunotherapy as well. These both entities, that is antifungal therapy and immunotherapy, has been tried in several studies, but there has been very few evidences which support their success. in comparison to endoscopic sinus surgery and glucocorticoid therapy. The success which has been reported in the few studies also says that their success is only limited to reducing the duration of postoperative glucocorticoid therapy. They do not prevent recurrences. Hence, there is no evidence of antifungal therapy in allergic fungal rhinosinusitis cases also. So now we come to the invasive fungal sinusitis. To begin with, we have acute invasive fungal sinusitis. So this will be manifested in immunocompromised hosts. So those set of clinicians who are treating immunocompromised hosts should be very aware of these early signs of the disease. So who are these immunocompromised hosts? They may be patients who are suffering from hematologic malignancies. They may be transplant patients who have received solid organ transplants or hematopoietic transplants. They may be the patients who have undergone chemotherapy. They may be advanced HIV or AIDS patients. They may be high-dose steroid therapy patients who have been receiving it for autoimmune conditions or dermatological conditions, or it may be patients who have uncontrolled diabetes mellitus. So whenever a clinician who is treating such set of patients finds that his patient is suffering from acute rhinosinusitis symptoms, which are severe headache, purulent nasal discharge, bloody nasal discharge, acute nasal obstruction, and postnasal discharge, along with loss of smell. So whenever patients present with these symptoms in immunocompromised hosts, immediately an urgent reference to ENT and ophthalm and neurology has to be given to assess the possibility of acute invasive fungal rhinosinusitis. Because these patients have rapid progression of symptoms and the disease will spread to the adjacent sinuses very rapidly. It will spread to the orbit very rapidly. It may spread into the intracranial structures very rapidly. So the patient may also sometimes present with disturbed vision or altered sensorium. So when such a reference is given, it is the responsibility of the ENT surgeons to take it as a surgical emergency and immediately post the patient for nasal endoscopy. Because early on, we may catch the pale turbinates and ischemic areas within the nasal cavity. We may also see eschars on the palate. So whenever such findings are seen, a biopsy has to be taken immediately and swab has to be sent for KOH mount, as well as culture sensitivity of the for antibiotics. So when nasal endoscopy has been completed, patient has to be urgently sent for ophthalmic assessment also, because patient may have changes in the fundus, and urgent neurological reference also should be given to identify early signs of focal neurological deficits. A combined CT and MRI of both brain and paranasal sinuses has to be done immediately. As we see in this picture, we see on the CT PNS that the sphenoid sinus has been involved with air fluid shadow in the sphenoid sinus. We also see that the adjacent posterior ethmoid sinus has been involved here. The same patient whose MRI was done shows that there are focal ischemic areas or infarcts on the bilateral temporal lobes of the brain. So combining MRI with CT will give a lot of more information than just doing a CT PNS or CT brain. So coming to the chronic invasive form of fungal sinusitis, here the set of patients are slightly different. They will not be as immunocompromised as in acute invasive form, but they will be older adults with mildly immunocompromised status. Who are these mildly immunocompromised patients? Those who are having long-term uncontrolled diabetes mellitus and those patients who are on low-dose steroids for a long duration for a variety of diseases. So the patients here, unlike in acute invasive form, will present with again chronic rhinosinusitis symptoms with single sinus involvement. The patient may go into orbital and neurological complications if they have ignored the sinus disease for a long duration. So these may be the warning signs as well. So when these patients are radiologically investigated with CT, nose and paranasal sinuses, unlike acute invasive form, we see only mucosal thickening and mass lesions within the sinus. There may be bony erosions if the disease has reached advanced stages. As we see in this picture, the sphenoid sinus on the left side has been involved with the erosion of the posterior plate of the sinuses as seen by the CTPNS. But in MRI, we can see that the adjacent cavernous sinus has also been involved along with the ipsilateral orbit. So this is the advantage of combining MRI with the CTPNS. So how do we treat this both acute and chronic invasive fungal sinusitis condition? So this is the one which is slightly difficult to cure because of the invasive nature of the fungus. So the fungus may spread hematogenously, may spread lymphatically, or may spread contiguously. So because of the invasive nature, it becomes difficult to clear the fungus from the whole body. So that is why the urgent basis antifungal therapy has to be begun. So the early biopsy which we would have finished would give us an idea whether the fungus is of the Mucorales group or it belongs to other fungus species like Aspergillus or Alternaria, etc. So if it belongs to the Mucorales group, which is also called as a mucormycosis or zygomycosis, so the treatment of choice will be amphotericin B, especially the liposomal form, which is less nephrotoxic. If that is not available, the other alternative will be posaconazole. If it belongs to other fungal species like Aspergillus, etc., voriconazole is the drug of choice. If that is not available, at least itraconazole has to be started immediately. So this is the early intervention that has to be done on an emergent basis. The surgical debridement has to be done as early as possible, but there is no evidence-based medicine that says that it has to be done within 24 hours. They have found a comparative study where it has been done within 1 week of starting the antifungal therapy versus doing the surgical debridement within 30 days. And out of both the studies, there has been no improvement in the overall prognosis of the patients. Hence, the surgical debridement has to be done, but it is not an emergency. It has to be done as soon as the patient is stabilized initially with antifungal therapy. But surgical debridement is utmost important because without clearing the fungus from the sinuses, it is not going to clear the ischemic areas because the IV treatment of antifungal therapy will not reach these necrotic areas. So these necrotic bone and mucosa has to be completely cleared either by endoscopic approach or by open approach. It has to go up to the periorbita or up to the dura with or without orbital exenteration. So whenever there is an infiltration of the fungus into the periorbita, we have to assess radiologically whether it has entered the optic canal. If it has entered the optic canal, then there is no advantage of doing an orbital exenteration as it has very poor prognosis. Either its entry into the intracranial structures or its entry into the optic canal or cavernous sinus has very poor prognosis, and in these cases, neurosurgical interventions with craniotomies have not been found to be beneficial in adding quality of life or giving better prognosis to the patients. Hence, the main surgical debridement will be endoscopic if it is early disease, or will be open debridement of the sinuses, open maxillectomy if it is advanced disease. So whenever the references are given, we must understand this difference between the approach that we have to take, because endoscopic disease gives relatively less comorbidity to the patient post-operatively, and patient will have a good quality of life, whereas open approaches will have a slightly diminished quality of life post-operatively. So this is the overall picture of fungal rhinosinusitis, where out of the 4 forms, It is only the acute invasive form which is so deadly and can be fatal for the patient. But the other three forms are indolent in nature, and out of them only the chronic invasive form will require antifungal therapy, and which will be of a prolonged duration. We may have to monitor the patient's antifungal therapy side effects like serum electrolytes or liver function tests, but patients will have a good quality of life if diagnosed early. So there is no panicking whenever somebody gets diagnosed with fungal sinusitis. An early intervention will definitely give a good quality of life, and in fact to the normal extent in the early two varieties, that is fungal ball sinusitis and allergic fungal rhinosinusitis. Thank you.